Am I leading this or you? I didn't plan that far ahead. All right. Welcome back to another episode of our what was supposed to be a full-length series that ended up as two episodes
Nice,
because
nice.
we got crazy busy. Also, it took me forever to edit up the last episode, which really wasn't a lot of work. But anyway, we're back. This is gonna be episode 9 of our clinical wrap-up. Uh,
hmm
Semi-tri-monthly instead of the weekly wrap-up.
Yeah,
Episode 10, regardless. So check in with you, Vince. Again, back to the 16-bit pixelated. We'll see how that goes when I yop it all down. How are
it's
things
fine.
going?
Overall, I would say everything's moving pretty smooth. I mean, my midterm meeting with my advisors went well. Uh, CI and I are getting along great. Definitely have come a long way in terms of managing the whole caseload or what he considers 100%. He still just takes patience because he gets bored, and I'm just like, I get that. I can't sit all day doing nothing and just watching people work. So there's a good, what feels like collaboration with a colleague and not so much an advisor, which is nice. And he's still feeding into me and like talking to me about stuff and like helping me see different perspectives on treatment, which is great. But it's now very conversational, which I love. And so I would say everything's moving right along. Started talking about some in-service stuff and what that's going to look like towards the end, and then just pretty much managing my own caseload now. I've done a slew of evals of all different body parts, so it's been great to be able to work with them so far and have them progress in their rehab.
What would you say most of your eval cases have been?
Um,
Or is there a few
I would
different
say
things that you are consistently seeing?
I've seen a lot. For some reason, I don't know what's happening, but I think I talked about in the last episode that my CI wants to cover every body part before he gives me an eval on that body part. But it'll be like the same day we talk about something, an eval will show up like that. And we're just like, this is like a weird occurrence of like same day, same eval kind of thing. But I've done some neck, back. Um, I did a hand yesterday, a wrist fracture. Um, Couple knees, couple ankles, all very like standard like work comp cases, a lot of like hurt at work, fell, too much activity, overuse injuries, stuff like that is kind of really where I'm seeing a lot. I have a couple patients that are dealing with a lot of chronic pain and are seeing like multiple specialists for it. And so managing that on top of their incidences has been kind of a juggling match of like dosing enough to see some gains while managing their pain on top of that. So it's been fun being able to think through all of that so far. But yeah, I've seen pretty much everything, honestly.
Nice, 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 nice.
Yeah. What about you? Let's hear it.
So also progressing along to basically approaching the full caseload. Um, Ours is a lot of overlapping patients, so I will see usually like 5, 6 patients in the morning, um, and then 3 to 4 or so, and the long days in my afternoons. So I work like 9.5, 10, 10.5, depending on like just how our schedule fills out. Monday, Thursday, and Wednesday, and or yeah, Monday, Tuesday, Thursday, and then Wednesday and Friday it's just mornings. Fridays we just have to because there's not enough people who want to be at Lilly to come to appointments, so we just don't schedule in the afternoon.
I
Um,
mean,
so that's
that's
why
nice.
it's really cool. It works out for me. I'm still seeing and working 35, 40 hours, but I do get 2 afternoons off, which is great for like having some sort of work-life balance. So it's definitely given me insight into how I think I would structure when given the opportunity when I'm employed and paid to be doing what I'm doing. Um,
Would you change your schedule in any way? Or would you try to keep that kind of four
no,
and a
I
half
really
day
like
week?
I really like it. It's really almost it's 40 hours and 2 half days, but I like going all 5 days and having 2 afternoons off. Um, one of the afternoons is usually like rest, reset, and like grocery shop, clean up,
Uh,
and then the other one's like, okay, I got time to mix in like a heavy training session afternoon. So it balances out really well.
okay.
Anyway, so the actual clinical, I've also done a bunch of evals, definitely seen a bunch of body parts. I'm getting really comfortable, I think, working with like lumbar pain, low back pain,
Hmm.
and hips, which I'm getting a lot of both, which obviously makes sense. We have a pretty highly active population. Um, I've got a couple people that are runners that I'm treating, which is really cool. Um, that I evaled and have basically been following along with their whole plan of care. And
Gotcha.
then I have um, conservative management CF ligament tear and
Full tear?
ATFL tear. They didn't give us the full op report on the C. Well, they gave us the op report, but it didn't specify specifically. Um,
What's your EMR? Do you guys have like available chart
it's a
review
built-in.
built in?
No, everything has to be faxed over for us.
Mm,
It's proprietary to ATI. I need to go back. I mean, it might have been in there, but the original thing that we got was there was a Volsion injury,
okay.
um, and they're treating it conservatively. So it's one of the lateral ligaments, and the ATFL and CF were both involved, and I can't remember which one was which.
Gotcha.
But that's been interesting. So because there was no like movement restrictions, it was entirely on me to determine what was safe, and so that's been cool because I've been going back to tissue healing timelines, talking with my CI, like what are these are the things that I'm seeing. This is how I want to progress it, getting their input, trying to be as independent as possible, but also don't want to put someone at risk of further injury. So it's
Yeah.
like
How are
confidence.
you?
It's more about confidence in myself.
Yeah. How are you educating the patient through all that? Are you just explaining it to them at all?
Um,
Because I had a,
yeah.
yeah, just this is stemming more from a case I had yesterday. Um, uh, older woman, Fuchs injury, fractured her distal radius, and she had no idea what was actually wrong with her because no one had told her yet. And it had been like
Mm,
almost a week, and she had no clue like what her injury was. She just knew that she was very hurt in her wrist. And so it now fell upon me to educate her on like what a fracture looks like for her and like where it is, what like all the charts are saying about it, and like proper healing timeline for like bone growth and stuff like that. And she was just like very grateful to finally know what was wrong. And I feel like that was
hmm
very much a missed opportunity on a lot of for a lot of people. So
But it fell to you to have an opportunity to do that with
yes,
someone.
I did have the opportunity. I feel like she should have known sooner, is what I'm getting at.
I agree.
Yes.
I agree.
But yeah, that's
Um,
some
so my lady didn't. She like knew. She was like, ah, they told me what it was. I said like a bone or a muscle like pulled off, and then I was like, I went through the full screening. We didn't get anything from the orthos or anything like that. So day one was like, we're gonna start with very minimalistic stuff. We're gonna focus on pain and swelling management, and I'm gonna get that op report and call over. So that was actually like, I was like, oh, I have to do some interdisciplinary communication. So I had to reach out to the ortho team and like, hey, like, do you guys have any things you guys can send over for us? And then so we got that. And then went through an education. She's like, oh, okay, yeah, that makes sense. I just remember it was not fun when I fell. And I was like, yeah, no, he tore a ligament. Also, not a muscle, it's a ligament. And so I got to educate her. I was like, I obviously nerd out about this stuff. I assume that
no.
you do too. So when it comes to educating people on stuff, like the thing that I've been talking about this guy, like I have to cut back. I have to cut back, which is interesting because it's a group of people that are highly educated, highly active, highly involved, and want to know, but it's a matter of not
Articulating, sharing,
overdoing it. Yeah,
elaborating,
yeah,
all those.
these are good words. Yeah. Um, so been trying to chop down all the words that I'm saying, be a little bit smoother, but I think my patients have really appreciated it. They definitely appear more bought in throughout the
Hmm.
session because I've definitely had some people that are like I know I'm supposed to be here, but I don't really know. Like, I get what you're saying. It all makes sense. And then throughout, as I like add things in from education wise, they start to be more and more like, oh, okay, like bought in and like ready to go, which has been really cool. This like I can actually see that
Yeah,
in over one session and over multiple
yeah,
sessions.
I could definitely relate to
Um,
that. I've seen some very anecdotal evidence of how that promotes healing in itself. We kind of talked with Ashley about it when we had that last podcast, about just
mhm.
like patient buy-in in that way and just like keeping them involved to some degree and like explaining exercises. And something I started doing in my evals is just like how much how much info do you like want to know about your injury? And generally they're just like, just keep it simple, please. And I was just like, all right, like, and then I'll go into a little like banter about like what this means for them, and then ask them like, does that make sense, or is there still some like gray areas for you? And then that just like makes it more conversational and not so much like dictating their whole rehab. So it's been really nice.
I like that a
Yeah,
lot. That's a good way to like. I'm taking that. That's a good
yeah.
question.
So it's been really helpful. And I've had a lot of patients, I feel like, enjoy their time a little more just because now they're learning a little bit more about their body and like how their injury affects movement for them. So obviously, like certain cases are a lot simpler to like run that through than others because of like underlying issues they may have.
Hmm.
But for the most part, it's served me well in this clinical.
Yeah, it might. I don't know. I really like that question. I think it's a really good way to one gauge how much you're gonna say,
Hmm.
but also encourages them to talk more.
Yeah.
Um, I definitely have a few cases. Is there anything else that I didn't go over about what's going on with mine? I think I kind of matched with the same questions that we both talked about.
Yeah. Good.
I have some cases we can talk about. Was there anything else
Um,
that we decided we wanted to do?
no, I think maybe before we get into cases, like talk to me a little bit about like where you're seeing a lot of growth. I guess we kind of talked about it a little bit, but like
Yeah,
maybe just
Clint.
point some out, maybe some
Yeah.
point out some more areas you can grow in now moving forward.
So one of the things that I've definitely noticed is, and so I started reading um, movement, the functional movement systems, FMS, SFMA
Hmm.
book. I got it, and I'm like a few chapters in. And one of the things they talk about is having a standard operating procedure that prevents personal biases jumping in. And so one of the things that I've noticed is like I use my experience a lot and it influences how I treat people, which is good because I have a way to relate to people. But then I also want to start mixing in things that I like that I really attach to, and I want to kind of pull back from leaning so heavily into that and more being like, um, this is dead air, good. Uh, I'm trying to figure how am I trying to phrase
You're
this.
good. Think it through.
I
Think
have
it
things
through.
that I really want to do that I think everyone would benefit from, but it might not always be the most specific and the most apt thing that they
So it's
need.
like,
So pulling myself back and just being more specific and direct to what the patient's needs
okay,
are.
so like falling away from like the catch-all exercises for a diagnosis and more patient-specific kind of tasking. That makes sense?
Yeah. Um, which so being like more specific in
Hmm.
that way where it helps address what's presented in front of me and not by something that I think they're going to be going into later. Which it makes that makes it sound like I'm just trying to make people me, and that's not what I'm trying to do. It's just I was like I know how to do this thing really well. Will it benefit them? Probably. Okay, but let's get back to what do they really, really, really need. So trying to like not let my personal biases affect how I treat uh, is one of the things that I'm trying to work on, and biasing and like in specific movement patterns and things that I like in that way, not necessarily like
Yeah.
biases culturally, but like how I like to move and train. Um, so that's one of the things that I'm like realizing that I've been unknowingly doing that I'm trying to pull
Hmm.
back from, and then being more specific with my dosing and progression. I have noticed, and this is something that I'm starting this week, like going through a plan of care, and this is where our flow sheet kind of makes things difficult, because it's so easy to start pulling old things and like, oh, but they need to warm up. Oh, we should probably stretch this. Oh, we should probably do this, and it makes you less present in the situation that you have with the patient in
Okay.
front of you. And so what I'm going to do going forward is like I'm going to take the flow sheet and spend a little bit more time like, okay, here, what have they done really well? Let's look at the past assessments. Let's what can we phase out and what needs to move in, and then let's make sure we're only holding things to 2 or 3 weeks if it's supposed to be a building block to the next exercise. If it's supposed to be a building block, and then if it hasn't made a difference, if it hasn't made a change, review with that patient. Are we doing it correctly? Yes or no? If so, maybe it's not the thing that you need and we need to change it anyway. So making things more progressive and sliding down as opposed to having this really long expanding list of stuff and
Okay.
building up a patient progression. One of the things like I'll go to is like lateral step down progressions. I've a bunch of people that I've been working with like patellofemoral pain syndrome, and I realized like for 4 sessions straight, I may have changed the intensity a little bit, and I may have changed the step height, but and it was like running and steps were a problem for 2 different patients, but I didn't change. Like I assessed, they were still doing all right. Their pain symptoms weren't really increasing, but I hadn't changed the actual exercise yet to be more apt to the things they want to go to. So one patient steps, the other important. We can hold that there because if they're working up with the other patient that I was working with, having PFPS, they might not need the step progression anymore. Why am I still doing it? And so like the last session, I phased it out, and that's what I want to keep
Hmm.
doing through these next couple weeks. Is like make sure I'm like assessing, kind of going back to like CSCS and training programs, use a meso period style where it's like 2, 3, 4 weeks, and then it's got to move on. Like you got to be moving to the next functional activity. Otherwise, you're going to be you're
Yeah.
holding them back. It might be helpful, it might be good for them, but it's not going to get them
Yeah.
back to their goal as quickly as maybe purposefully changing things to be more direct towards their goals. So I think those are the things that I'm working on, and then time management. I love to spend time with patients. Unfortunately, in our clinic, we have a lot of overlapping, so I got to be really good in the first 30 minutes of seeing a patient. It's like, what is the manual therapy that they need? Get it in. What are new exercises I want to teach them on? Get it in. And as their follow up things that they're really good at that they can start doing with a little bit less supervision or with
Hmm.
the tech watching and hand them off because I have the next patient coming in on the half hour. All right, what are the things I need to do with this patient? And so really structuring my sessions and then also seeing what I'm seeing and I can have a great plan. They can present differently. Okay, how fast can I pivot? Still get all the things they need, and then go back to things that they're able to do more on their own, where I can watch from afar while treating someone else.
Okay. I hear you. I think that's all,
Those are the 3 things I think.
yeah, I think that's all really good. I especially like the progressing appropriately and in an appropriate timeline. I think that's something I've done pretty well overall. I hate doing the same thing twice for a patient. Like, I don't want them to come in and expect the same thing every day. Because I have some patients that it's like we do stretching every day because that is their biggest deficit, just like muscle length issues, and it's one of the main contributors. So they like have that expectation that they're gonna like, oh, we're gonna stretch a little bit, but the Therax and the Therac they're doing is either gonna be maybe a little more intense or a little variation of what they've been doing, just to give them some new learning curves for them to work around. And so far, a lot of it has been like almost neuro re-ed in sense of explaining movement mechanics. Because in the work industry and like in industrial industrial athletes, I love that term. Uh, for, yeah,
Hmm.
for
Good,
industrial
good
athletes,
term.
it's like a lot of times like their background and like movement and exercise is like very like average or like below. Very now and again, while I meet one that's like very advanced and very like well informed with it all. And it's a lot of just like, okay, these are the proper ways you move. This is how you use your hips. This is how you tighten your core. This is how you like can properly brace and like teaching them safe ways to move around. And I think that's been the kind of the most fun part of this clinical is like, how do I make very like action specific movements that are going to like help them learn to use their body while also progressing them like steadily. So I've tried to get a little creative. There's, I do so much like core work with all of my patients, and I really enjoyed doing more like sling exercises. So like the cross body slings, like posterior sling, anterior sling, all of those.
Mm,
I think those are very helpful uh, body mechanics to understand because in my setting in particular, it becomes huge for like patients that have like low back pain, hip pain, stuff like that. And it's a deficit that's easily addressed with these exercises.
how much are you doing when you're putting someone on a sling? So say they have like low back pain with a specific referral side. How much are you doing then moving opposite to like looking at that right shoulder mechanics? Because I do remember uh, talking with Kim at one point that like she remembers having a patient when she was going over reviewing sling with us in our like
Hmm.
last little bit before they sent us out. Um, like I was looking at I was treating the back, I was treating the hip, it was getting better, but they were still experiencing pain with sport or like their thing. Like they could do all the things that we were treating them to do, and they were better there, but they weren't back to the thing without it. And then they started treating the opposite region. So they went from left hip to right shoulder and noticed that there were deficits there. Once that got better, this didn't have the
Hmm.
pain with the actual task that they were trying to do.
So,
Have you done much of that?
to some degree, I think I'm not isolating my care to that region only because of work comp restrictions and not being able to like fully address one side that's not the involved side, essentially. Um,
Right.
the whole thing with it is making it dynamic and involved. So keeping pushing them as far as you can without like crossing that pain threshold essentially and incorporating
Mhm.
that into movement. So if I'm having them do like a single leg RDL, essentially, I'm having them hold weights on this right side if it's their left hip or left leg and showing them like, okay, when you come up, I want you to cross in, or just doing like seated abdominal bracing with like a Swiss ball. So I'm having them push in with their right shoulder, push up with their left hip, and addressing that is anterior cross sling, where it's the front X essentially. And
Yeah.
so it's like making it a whole body movement, if you will, to help address both. And that's pretty much how I umbrella it and like cover it. If I ever need a,
So you can still document that the focus is.
Mhm. So
Mm,
that's been my workaround so far. And private practice would be a lot easier to do it all because it's like, oh, like we're doing this for that and stuff like that. And then you can also address it as like in your assessment portion for our EMR, you just have to be really well like written about it and just like explain in thorough like this is involved and why. And that was the conversation me and my CI had. It's like, yes, we're supposed to treat the involved side, but if you notice things that can't contribute, just explain, and then insurance will have to accept your professional opinion.
yeah.
Yeah, so
Interesting. I like that. That's cool. I need to bring back some of that stuff. We have direct access, so it's kind of unfettered on what we need to treat for those 42 days, unless
mhm,
it's a work comp case. We do have some work comp stuff. I would say that's maybe 12%, I think is what um, the regional director, I worked with the regional director for one day. Um, and so we got to talk a little bit about the business side and expectations for clinicians and units. And here's where the primary, the majority of reimbursement is coming from based on these insurances in these cases. I think it's like 12% is work comp. So we do have that, but for most of it, it's Lilly Insurance, which is great because I'm working inside of a corporate entity and they bring us in house so they can see us super
mhm,
easy. They just block it off on their schedule. They walk down and they come find us.
yeah,
And most of them are coming to see direct access. Like, yeah, I got back pain. Can you treat me? And it's like, yeah, let's schedule an eval and then we can do anything we need to do.
That's fun.
It's almost kind of like having a cash payout, but there's limitations. Of course, you can't. You still have to validate why you're doing the things that you're doing, unless the work
All
complicated, in which
right.
case you have to be a little more specific.
And I think in
Which
that we should always be able to justify our treatment choices. So it's like,
we wouldn't do it if we didn't have a reason to do it. It's just
exactly.
a matter of, are we going to see the reimbursement for it on the backside?
Yeah, whoever's paying for it wants to know why. Even though
Yeah,
they may not understand, in my opinion, but they need to see the docs on it.
yeah. Do you have any cases? Do you have any pop up in your head that you wanted to talk about?
Mm, I don't have. See, I have what I would consider very like almost generic cases of like work injury, like low back and stuff. We had, I did have one cervical eval that ended up being a lot more complicated than I think me or my CI bargained for. Um,
Mm-hmm.
Patient just has a lot of underlying issues, and um, the incident was motor vehicle accident, got T-boned, and pretty much
Mm-hmm.
jostled
Ooh.
like a sideways whiplash sort of deal. No
Mm.
concussion, no brain injury issues, all imaged and cleared. Um, Patient's only like big complaint is like some stress and like soreness and like tenderness in their like shoulder. So we were doing some chart review. We're like, okay, like it may not actually be like cervical, like they could have like some shoulder involvement. So after subjective kind of lateral to one or the other. And it turned out to be more cervical. But what wasn't mentioned in the chart review was they had a three segment fusion in their cervical spine, is seeing a spine specialist and a pain specialist about chronic pain, radiating pain all the way down to their toes, and basically has no range of motion in their neck, secondary partially to three fused segments. And
Yeah.
so we were like, okay, let's address a couple things. Their AA and OA motion was pretty standard, but anything beyond like any overpressures caused a lot of pain for him. And it wasn't because of their incident. And he would always address like, okay, like this was hurting prior, this was hurting prior. And the only thing I found that was like new for him was a trigger point in his shoulder. So we're going to be dry needling him in the future.
Nice.
So that was my C and I were talking about like how do we discern for him what is new onset and what is old. And then he's not very outspoken about his pain and will just toughen up and just muster through whatever I give him. So it's a lot of
Mm-hmm.
like me overemphasizing communication. And I worked with him a couple times already. I've had him for about a week. He's like, I think he's getting tired of me asking like, how does this feel? What are you feeling? Like, tell me how this is. But we had a good talk last time about how it is important to know how you're feeling and like understand like what movements hurt, and that's going to help us better address the issues he's having. And essentially, like I told him, you can cross it over into any specialist you see because they also are concerned with it all, and it helps them further deduce like ways to treat and ways to help you. So I was like,
Mm-hmm.
really try to like think about it and let us know what's hurting. And that went a long way. We found some exercises yesterday using a Pilates ball that were helping. He said they felt really good for him. So I was like, all right, let's do a few of these. Let's calm you down and stuff like that. So we had a small little breakthrough last session with him. So that was good.
Nice.
I would say that's been like my most interesting case so far. And
That's
he's
pretty neat.
yeah, he's pretty recent. So we'll see how he progresses.
So you said AAOA or AAO. What the
AA and
top
OA.
joints? this,
Yes, top.
this stuff that cleared, and was all right, and then some trigger points, and then just some range of motion is where you guys are mostly at.
Mm-hmm. Oh, and he has a chronic
Cool.
headache.
Did you check subox, cervical paraspinals, and all that stuff, levator?
He has tone all throughout. The biggest thing I found was I was able to reproduce his headache with um, some pressure to like his fuse segment. So checked all like cervical like extensors, uh,
Mm-hmm.
added a sustained hold just to see because there was a lot of tone and I was just like I'm just gonna hold here like during my manual. And he's like that's shooting right up into my eye, and I was like oh all right. So started doing some
Did,
like soft tissue with movement just to see if it would calm down. And
uh-huh.
this was before our conversation, so he wasn't really telling me much after that. And I was like, all right, like let's lateral. I think I'm just causing you a little more pain. So we moved on.
Interesting. I've had a couple patients that are also having cervicogenic with, I can't remember. I see a bunch of cervical patients, um, upper limb
Yeah.
dwell tension, headache, posture, just neck pain, because a lot of people are office people, and so it's interesting seeing all the cervicogenic headaches that you're getting just from manual reproduction on tight muscles. And then like I'm like, do you feel that? Where do you feel it? Top of my head. Okay, we're just gonna sit here. We're just gonna sit here on it.
Yeah.
See if we can get it to loosen up. And then I'm like, all right, it's been a minute. How are you feeling? He's like, it's actually it's lower. It's back towards my neck now. I was like, huh, crazy. Who'd thought?
Yeah.
Headaches are fun to treat.
Yeah. It's so interesting. And then when I asked them to like describe their headaches, because obviously like headaches in themselves have different patterns they take, and they're just like, oh, just here. And like I'm just like, okay, wait, Ranthorn or
Whoa.
where? And then there's like, well, like no, like the side, and like they'll do like this generalized, like it's just my head. And I'm just like, really take a second,
Let's
like think
narrow it
about it.
down.
Yeah. And so that's been fun to like help people look inside themselves, if you will.
There's been a lot of trying to bring people's awareness to what they're feeling
Yeah.
and trying to differentiate between what's pain, what's stiff, what's tight, what's sore, what's
Hmm.
is it burning? Does it feel like it's stretching? Like trying to really engage people to think about what they're feeling has definitely been something that I've been working on. I do feel like, oh, how's that feel? What's this? Does that hurt at all? Like I may over ask, but I am. It's because I'm trying to do what we just said. It's
Hmm.
trying to bring awareness to what they're feeling, and I do want to keep working on my tact with it, my delivery with it, so it doesn't feel like I'm just
Yeah. I think delivery is the biggest
skipping
thing.
track on repeat.
Yeah. Not asking
But
the
it's really
same.
fun to see how people are. Go ahead.
No, I was just not asking the same question twice. Even if it's like
Yeah.
in general.
So technical difficulties as usual, but we're good at working around it.
Nice.
But yeah, basically just not asking the same thing over and over again, getting better about how you deliver, being specific with your language, but not saying the same thing just on repeat. Engage people to feel what they're feeling so that you get a better, clear picture, they get a better, clear picture, and it's easier to treat. Boom. I think that was
Well
pretty much
said.
where we were at.
Again.
Yeah. Um,
Excellent.
Okay, should we wrap this and go to in services, or should we talk through a couple cases, or should we save some cases
Mhm.
for like the wrap up at the end where we've had a couple people where we've gone through a full kind of up to you.
I don't know. I don't have any more cases to really share about that are like these are neat. I have a couple long-term ones I can really talk about, but overall, I think it's good. We could wrap up and then go to talking about our next episodes, our in-service episodes.
Cool. I'll let you. This is your idea, so you lead it.
Yeah. So after this, since we kind of want to add more to the series, me and Vito are going to be presenting to each other our in-services that we will be presenting to our clinics in the coming weeks. Um, Mine's related to femoral acetabular impingement syndrome, and then Vito, you want to tell me which one yours is about?
I'm doing overall cervical radiculopathy,
Okay, sweet. And
non-specific.
so we'll be dropping those sooner rather than later. Gonna try and get these out pretty succinctly, and then just in time to drop our end of CE3 wrap up episode too. We call that our final one for this series, and then talk about plans for the future.
Cool.
Yeah. Anyways, see, there's a little lack of conversation and communication on this, but thanks to all for tuning in and giving us a listen. Hope you enjoyed. If you have any questions, feel free to email Vito or I or our unboxing email. We do check that semi regularly. We check it enough, I should say.
I
Um,
check it.
you more than I do.
Considering you just got the login today.
Yes, yes, absolutely.
I check. I check. All right.
All right.
Until next time.
Yeah. All right. Peace, y'all.